Hey everyone, today we are going to talk about a very big, very important, very interesting, very rich article about fat containing retroperitoneal lesions. There are a lot of lesions in the retroperitoneum that can contain fat. We need radiology and we need to try our best to differentiate which is which. Your colleague, Dr. Dindar, will talk about it and you might present. This is the laser point. Okay.
Fat containing retroperitoneal lesions, imaging characteristics, localization, and differential diagnosis. Introduction at ultrasound, the echogenicity of fat can be variable. It is typically hyperechoic and may demonstrate posterior acoustic shadowing. CT images derives their contrast parameters predominantly from the physical properties of tissue. These, along with the high spatial resolution of CT, provides accurate tissue attenuation measurement. CT attenuation measurement are quantitative, with -10 to -100 Hounsfield unit corresponding to fat. However, CT is limited in the demonstration of mild intracellular fat deposition or small amounts of macroscopic fat. There are two MR imaging techniques for identification of fat within a structure. Fat saturation. Fat saturation is best for diagnosing macroscopic fat, as it requires a greater degree of steatosis. Chemical shift imaging is an ideal technique for identification microscopic fat or intracellular fat in a lesion or organ. Yes. Fat infiltration, yes. Yes. It's fat infiltration. Fat. Yes. Some important signs for determination of the organ of origin of the retroperitoneal lesions. Multiple imaging signs help to determine the organ of origin, including the big sign, the embedded organ sign, the phantom invisible organ sign, and the prominent feeding artery sign. In this picture and in this drawing and in this CT image, we see a positive big sign. The drawing shows sharp angle at the interface of the mass and the kidney surface. And the CT image show a simple renal cyst. It is clearly show the sharp beak-shaped interface between the lesion and the kidney. We have a negative beak sign. There is no sharp interface between the mass and the kidney. Another sign, a negative embedded organ sign. Here we see that the mass is not inside the organ. Drawing show a tumor compressing a hollow viscous organ, which assumes a crescent shape. This MRI image shows a retroperitoneal paraganglioma compressing the inferior vena cava and causing it to assume a crescent configuration, as seen, crescent configuration. Positive embedded organ sign, as seen in this CT image, the contrast inside the bowel lumen surrounded by a mass, embedded in the mass. First, fat-containing adrenal lesions. We have a common diagnosis and rare diagnosis. Common diagnosis, adenoma and myelolipoma. While rare diagnosis, carcinoma, Pheochromocytoma, neurogenic tumors, Angiomyolipoma, lipoma, and liposarcoma, and metastasis. First, adrenocortical adenoma. Adrenocortical adenoma is the most common adrenal lesion found in 2 to 9% of all autopsies. Most adrenocortical adenoma measures 2 to 1/2 cm, rarely measuring up to 4 cm. They usually are well circumscribed, homogeneous on non-enhancing images, and show homogeneous contrast enhancement. Adrenal adenomas typically contain variable amounts of microscopic fat, which is called intracellular lipid, and can be classified as lipid-rich or lipid-poor according to the lipid content. The attenuation values of adenoma depend on the amount of lipid. Lipid-rich adenoma is diagnosed when an adrenal lesion measures less than 10 ounce-fold unit on an enhanced CT image. Measurements of attenuation below 10 ounce-fold unit effectively exclude malignancy. Attenuation measurements greater than 10 ounce-fold unit indicate indeterminate lesions that may be lipid-poor adenoma or malignancy. Lipid-poor adenoma constitute about 10 to 14% of adenomas, 40% of adenomas, and demonstrate higher attenuation on a non-enhanced CT image. Threshold value for more than 60% for absolute contrast material washout and 40% for relative washout have been found to be highly specific, sensitive, and specific for diagnosing adrenal adenoma. By MRI chemical shift imaging with in-phase and out-phase sequences is the most reliable MR imaging technique for diagnosing adrenal adenoma. Most of these lesions demonstrate a decrease in signal intensity on out-of-phase images when compared with in-phase images. A decrease in signal intensity of more than 16% is considered diagnostic of an adenoma. Rarely foci of macroscopic fat have been reported in adrenocortical adenoma, resulting in a misdiagnosis of myelolipoma on images. Such lesions were found to be adenomas with myelolipomatous and or lipomatous changes at post-operative pathologic evaluation. This is the equation formula. Yes. Yes. This is MRI images of in-phase and out of phase. We see a significant signal drop on out of phase image. other organs, we see the India artifact. Another subject which is common, adrenal myelolipoma. Myelolipoma is the most common macroscopic fat-containing adrenal mass. Myelolipoma is uncommon, benign, non-functioning tumor that is found incidentally at imaging and ranges from 2 to 17 cm in diameter. Pathologically, a myelolipoma is composed of adipose and hematopoietic tissues. It commonly originates from the adrenal gland and rarely originates from an extra-adrenal location. At imaging, a myelolipoma typically appears as a well-circumscribed mass that contains variable amounts of soft tissue and macroscopic fat. A pseudocapsule has been reported in 75% of cases with calcification in 24% of cases. A case of adrenal myelolipoma contrast enhanced CT image show a right adrenal mass that contains macroscopic fat. The mass has higher attenuation than that of retroperitoneal fat because of the myeloid element. It's not just fat. Congenital adrenal hyperplasia. Congenital adrenal hyperplasia results from 21-hydroxylase deficiency. Prolonged stimulation of the adrenal cortex typically leads to enlarged adrenal glands, bilateral enlargement of adrenal glands, occasionally associated with multiple fat-containing adrenal masses. This appearance has been rarely reported in the literature, although this diagnosis may be underreported because these lesions mimic the appearance of myelolipoma, which seldom exists bilaterally. Myelolipoma is seldom exists bilaterally; it's unilateral, while congenital adrenal hyperplasia is bilateral. A case of enlarged bilateral enlargement of both adrenal glands, with the left contain multiple fat signal lesions. Pheochromocytoma, a paraganglionic system, is composed of neural crest cells which are found in the adrenal medulla, parasympathetic ganglia, and chemoreceptors. Tumors that arise from the adrenal medulla are called pheochromocytoma, and those that arise in extra-adrenal lesions, 10% are referred to as paragangliomas. Pheochromocytoma is typically symptomatic, occurring with new onset, paroxysmal refractory, or recently exacerbated hypertension, headache, flushing, and palpitation. Pheochromocytoma has been shown to follow the rule of 10, 10% being malignant, 10% being bilateral, 10% extra-adrenal, and 10% assumed occurring in children. Pheochromocytoma can be associated with multiple endocrine neoplasia, von Hippel-Lindau disease, neurofibromatosis type 1, and non-syndromic familial pheochromocytoma. On contrast, enhanced CT images, pheochromocytoma demonstrate heterogeneous enhancement and thus can have non-specific imaging manifestation. 1/3 of pheochromocytoma mimic lipid-poor adenoma with an absolute enhancement washout rate more than 60 and relative washout rate of more than 40. On MRI imaging, most cases show high signal intensity on T2 images, which is called light bulb sign. However, marked increased signal intensity on T2 image is not as common as was previously thought. Case of adrenal pheochromocytoma. Yes. Adrenocortical carcinoma. It is the most common adrenal primary malignancy. Adrenocortical carcinoma is rare, affecting approximately 2 patients per million and occurring in patients 30 to 70 years of age. is an aggressive malignancy with poor prognosis. Most of the tumors are functional, with approximately 60% of patients expressing endocrine symptoms, typically characterized by Cushing syndrome. Typically, adenocarcinoma appear as a large mass, usually larger than 6 cm. These tumors typically exhibit heterogeneous contrast enhancement and have the degree of heterogeneity and large size are more reliable for diagnosis than contrast material washout measurement. Adrenocortical carcinoma has been rarely reported to contain foci of microscopic or macroscopic fat. Myelolipoma vice adrenocortical carcinoma. Fat-containing adrenocortical carcinoma have only a small amount of macroscopic fat relative to the overall lesion size. This may be a helpful clue when determining the diagnosis. A small myelolipoma may contain small amount of fat, while larger myelolipoma usually contain large amount of fat. Hypertension or evidence of adrenal hormonal excess favors diagnosis of adrenocortical carcinoma rather than myelolipoma, which is asymptomatic. Myelolipoma can demonstrate enhancement, however, a large heterogeneous mass with substantial peripheral enhancement more likely represent adrenocortical carcinoma than myelolipoma. A case of adrenocortical carcinoma. Yes. Yes. Very late. Adrenal angiomyolipoma is a rare benign mesenchymal tumor that consists of mature adipose tissue, smooth muscle, and blood vessels. Usually arises from the kidney. The liver is the most common extrarenal location. About 50% of angiomyolipoma are associated with tuberous sclerosis. Few cases of angiomyolipoma have been reported to involve the adrenal gland, and the presence and the appearance is indistinguishable from that of the adrenal myelolipoma. A case of adrenal myelolipoma shows signal intensity loss seen on the fat suppressed T1 images. Yes. Fat suppression on T2. Adrenal lipoma are small benign tumors of mesenchymal origin that contain mature fatty tissues and are surrounded by fibrous capsule. Only a few cases have been reported to involve the adrenal gland. Adrenal lipoma appear a well-circumscribed homogeneous fatty mass. In contrast to myelolipoma, or minimal soft tissue attenuation should be visualized within the lesion. As seen in this case, fat-containing renal lesions, we have angiomyolipoma, the most common. Others are rare. Renal angiomyolipoma is the most common benign mesenchymal tumor of the kidney. Pathologically, it is composed of fat, smooth muscle, abnormal blood vessels. Yes. Angiomyolipoma may be sporadic or occur in association with tuberous sclerosis. The sporadic form accounts for 80 to 90% of cases and is most common in middle-aged women. Most cases are readily diagnosed because of the predominant macroscopic fat content. Thin section CT is preferred for diagnosing angiomyolipoma when there are small amounts of fat. Loss of signal intensity on gradient echo or spin echo MR imaging acquired with fat saturation is diagnostic of angiomyolipoma. At chemical shift MR imaging, detection of India ink artifact at fat-water interface is also highly suggestive of angiomyolipoma. We have angiomyolipoma with minimal fat are tumors in which intratumoral fat cannot be seen on CT image and there are a predominant of blood vessel and muscle or immature fat. There is important overlap between CT and MR imaging finding of angiomyolipoma with minimal fat and renal cell carcinoma. Angiomyolipoma with minimal fat are usually hyperattenuating relative to the renal parenchyma on non-enhancing CT image and hypointense on T2 weighted images that reflect the predominant smooth muscle component and classically overlap with the features of papillary renal cell carcinoma. Findings suggestive of diagnosis of angiomyolipoma with visible fat include without visible fat, an angular interface between the mass and the underlying normal renal parenchyma, a low attenuation rim at the periphery of the mass on non-enhancing CT image, homogeneous attenuation, absence of calcification, and presence of other lesions with classic imaging features of angiomyolipoma. I bring these pictures from another article, how we differentiate between angular interface and round interface. It says that angular interface is almost always benign, while round interface most of the time is malignant. This between angular interface and round interface. This is the second one is angular. This one, the round. This is angular. Yes. Presence of an angular interface with normal renal parenchyma is a strong predictor of benignity in an exophytic renal mass with high diagnostic accuracy. Calcification within an angiomyolipoma is exceedingly rare. Invasion of the renal vein is a rare but recognized complication of benign angiomyolipoma and does not imply malignancy or metastasis. Yes. Contributing factor to development of renal vein invasion include large size and central location of the angiomyolipoma. Differentiating an exophytic angiomyolipoma from perinephric liposarcoma can occasionally be difficult, as both conditions appear as a fatty mass with a perinephric within the perinephric space. Features that strongly favor an exophytic angiomyolipoma are renal cortical tumoral vessel, renal parenchymal defect, usually with an angular interface with a normal renal parenchyma at the site of tumor contact, whereas the tumoral calcification are suggestive of perinephric liposarcoma. As seen in this case, a very large angiomyolipoma, and there is invasion of the renal vein by fat. Yes. The renal cell carcinoma, presence of fat within a renal cell carcinoma is a rare phenomena. Most fat-containing renal cell carcinoma contain calcification in close proximity to fat foci. Renal cell carcinoma that contain fat without calcification are extremely rare. Yes. Because because of the smooth Because of the smooth muscle content, angiomyolipoma with minimal fat are typically hypo-intense on T2 MR imaging and can be readily differentiated from clear cell renal cell carcinoma, which are typically hyper on T2 weighted images. Therefore, on an enhancing renal mass that is hypo-attenuating on enhancing CT image and hyper on T2 weighted MR imaging is more likely to be renal cell carcinoma than angiomyolipoma with minimal fat. On the other hand, papillary renal cell carcinoma are also typically hypointense on T2-weighted MRI imaging and hyper-attenuating on non-enhancing CT image. Therefore, a homogeneously enhancing renal mass that is hyper-attenuating on non-enhancing CT images and hypointense on T2-weighted images could represent an angiomyolipoma with minimal fat or a papillary renal cell carcinoma. Percutaneous biopsy is the only way to distinguish between them. The case has soft tissue. There is calcification. Foci of fat. This is a rare case of renal cell carcinoma and contain fat, small foci of fat attenuation with no visible calcification. Yes. Renal lipoma and liposarcoma are extremely rare. At imaging, renal lipoma appear as a well-circumscribed homogeneous mass that is almost exclusively composed of macroscopic fat. Soft tissue component and feeding vessels are rarely seen. Renal liposarcoma is a rare tumor with only a few documented cases. The imaging appearance of liposarcoma varies depending on the tumor grade. Poorly differentiated tumor, however, appear as a locally invasive, predominantly soft tissue mass with variable amounts of fat. A case of renal lipoma and a case of renal liposarcoma, showing a very large mass with substations inside. We have another condition, renal replacement lipomatosis. Is a rare benign pathologic entity which marked atrophy of the renal parenchyma is accompanied by extensive fibrofatty proliferation of the renal sinus and perinephric space. The condition is usually unilateral and may be segmental. In most cases, it is secondary to calculous disease, resulting in hydronephrosis and chronic inflammation. Renal replacement lipomatosis can be differentiated from fat-containing neoplasm that arise from the renal parenchyma, renal sinus, renal capsule, or perinephric space by diffuse uniform distribution of fat within the renal sinus and perinephric space, and marked loss of renal parenchyma, loss of renal function, and renal calculi. As seen in this case, atrophic kidney we see as stone, and the hypertrophy of the surrounding perinephric fat. Management of fat-containing renal lesions. Predominantly fatty renal mass is almost always angiomyolipoma. Small, less than 4 cm angiomyolipoma have traditionally been managed conservatively because of the absence of malignant potential and low propensity for hemorrhage, but follow-up is recommended to assess growth. Symptomatic tumors or tumor larger than 4 cm can be selectively embolized or resected with partial or radical nephrectomy. Other lesions with large fat component include lipoma and liposarcoma. Differentiating renal lipoma or well-differentiated liposarcoma from angiomyolipoma may be difficult. Angiomyolipoma may contain large aneurysmal vessel, while lipomas and liposarcoma are relatively avascular and rarely occur with multiple lesions, as may be seen with angiomyolipoma. Biopsy is usually required in large lesions. However, follow-up may be adequate for small, purely fatty lesions. Poorly differentiated liposarcoma is more invasive and contains variable amount of soft tissue elements. Fat-containing renal cell carcinoma may contain subtle sparse area of fat within a predominantly fat soft tissue mass and can be readily differentiated from classic angiomyolipoma, which usually contains abundant amount of fat. The main differential diagnostic consideration for fat-containing renal cell carcinoma is angiomyolipoma with minimal fat. The latter is almost always small and less than 3 cm and lacks calcification commonly seen in renal cell carcinoma. Fat-containing pancreatic. Fat-containing pancreatic lesions, we have pancreatic lipoma. Incidentally found during abdominal imaging and are more common in the pancreatic head. At imaging, pancreatic lipoma appear a well-circumscribed homogeneous mass with a sharp interface with a normal pancreatic parenchyma. Calcification are characteristically absent in pancreatic lipoma. Larger, more than 5 cm fatty pancreatic mass with irregular border, with evidence of infiltration. And areas of soft tissue attenuation should raise suspicion for pancreatic liposarcoma. Further evaluation is indicated. A case of pancreatic lipoma will define fatty density lesion in the head region. Pancreatic mature cystic teratoma. We have pancreatic teratoma represent a rare entirety with fewer than 50 cases described. The imaging appearance of pancreatic teratoma is the same as that of teratoma elsewhere, with heterogeneous appearance due to multiple tissue components, fatty and or cystic masses with fat fluid levels. Coarse calcification are usually present with or without soft tissue component, which help differentiate mature cystic teratoma from the more common pancreatic lipoma. The echogenicity of pancreatic teratoma varies on abdominal or endoscopic ultrasound, ranging from hypoechoic to hyperechoic finding relative to the normal underlying pancreatic parenchyma. A case of pancreatic mature cystic teratoma shows calcification. Yes. Fat replacement of the pancreas is the most common pathologic finding in the adult pancreas. It can be focal or diffuse, and it can mimic a pancreatic mass. Yes. It is most commonly in patients with cystic fibrosis. In adult patients with cystic fibrosis, complete fatty replacement is the most common pancreatic finding on imaging, with a report prevalence of 50 to 75%. It is most commonly identified in older patients. Lesser degree of diffuse fat replacement common in patients with diabetes, metabolic syndrome, steroid use, chronic pancreatitis, or obesity, and in the elderly. Focal fatty replacement of pancreas may resemble pancreatic mass. It typically involves the anterior head with sparing of the posterior head, and the uncinate process may demonstrate mass effect and contrast enhancement due to interrupted normal parenchymal tissue. Non-enhanced CT is usually adequate. CT is adequate to confirm its fatty nature. However, a mild degree of focal fatty change in the pancreas can be difficult to diagnose with CT alone because the attenuation value may be in the range of fluid attenuation value. Area of focal fatty replacement may show a contrast enhancement of CT because of the enhancement of normal pancreatic parenchyma interrupted between fatty replaced parenchyma. Chemical shift imaging is diagnostic for confirming focal fat change in the pancreas by demonstrating signal loss on opposite phase image when compared with in-phase image. Case of pancreatic lipomatosis, abundant fat surrounding. Management of fat-containing pancreatic lesion. Pancreatic lipomatosis is a diffuse process that involves the entire pancreas and is easily diagnosed at imaging. Focal pancreatic lesions include lipoma, liposarcoma, mature cystic teratoma, and focal fatty replacement. Lipoma is well circumscribed and homogeneous, features that help to differentiate it from a focal fat replacement. The presence of fat fluid level and coarse calcification with or without soft tissue component can differentiate pancreatic mature cyst teratoma from pancreatic lipoma. Differentiation of fat-containing pancreatic lesion does not have clinical significance, as none of these lesions require intervention or treatment. The most important issue in this case is that the presence of fat helps us to exclude the diagnosis of adenocarcinoma and neuroendocrine tumor, which are not known to contain fatty elements. The only exception for fat-containing pancreatic mass that require intervention is the rare pancreatic liposarcoma. Those tumors are usually large and heterogeneous and contain soft tissue element together with fatty component, and biopsy or surgical excision is required. Yes. Retroperitoneal lesions, we have retroperitoneal lipomatosis is the benign metaplastic overgrowth of mature unencapsulated white fat. The condition usually affects the extraperitoneal pelvis and less commonly affects the abdominal retroperitoneum, specifically the perinephric space. White fat. Lipomatosis is more common in men with a ratio of man to woman 18 to 1, particularly African American men with a mean age of 48 years. There is no statistically significant association with obesity. CT and MR imaging show expansion of the pelvic or retroperitoneal fat with mass effect on the pelvic and abdominal structures, pushing the bowel loops anteriorly and compressing the urinary bladder, resulting in a pear-shaped bladder. Few fibrous strands may be present, but there is no enhancing soft tissue component. The uterus may be displaced medially, and the femoral veins may be stretched. Here we see retroperitoneal lipomatosis. Yes. This is human, this case, human immunodeficiency virus related lipodystrophy. Long-term of use of antiviral therapy leads to maldistribution of fat in the body. There is lipodystrophy is related to subcutaneous fat loss and typically involve the limbus, while lipohypertrophy consists of accumulation of adipose tissue and usually involves the retroperitoneum, breast, anterior neck, and dorsocervical. Yes, yes, yes. As seen, as seen in this case, you, yes. Another condition, retroperitoneal panniculitis, mesenteric panniculitis, is an inflammatory process of mesenteric fat. It is a rare condition characterized by chronic mesenteric inflammation. It is usually involved the mesentery of the small bowel, especially at its root, but occasionally it involves the mesocolon, peripancreatic region, omentum, retroperitoneum, or pelvis. The CT appearance varies from subtle increased density of the mesenteric and retroperitoneal fat to a solid soft tissue mass. Preservation of fat around the mesenteric vessel, fat ring sign, and a tumoral pseudocapsule have been described in patients with mesenteric panniculitis. Retroperitoneal involvement can be differentiated from other conditions involving the retroperitoneal fat by the typical coexisting involvement of the mesentery. As seen in the case, there is hyperattenuation of the mesenteric fat. Retroperitoneal fat necrosis is usually caused by lipolytic effect of pancreatic enzyme related to acute pancreatitis, usually accompanied by pancreatic parenchymal necrosis, but can occur without visible pancreatic involvement. On CT, the involved retroperitoneal fat show increased density, more than that of normal retroperitoneal fat, with scattered nodules and thick septa. The process may extend into the various retroperitoneal compartments, the small bowel mesentery, and the transverse mesocolon. The process may traverse the strong perinephric fascia to involve the perinephric compartment. Clinical history of a prior episode of acute pancreatitis is usually helpful in diagnosis. Other causes of retroperitoneal fat necrosis have been reported, including long-term use of steroids. Encapsulated fat necrosis is a degenerative process that involves mature adipose tissues and is much more common in the breasts and extremities. It is thought to result from a traumatic or ischemic insult that causes fat degeneration. However, the exact pathogenesis is unknown. The imaging appearance may be complex. Fat attenuation lesions contain linear or mass-like fluid or show soft tissue attenuation and are surrounded by a thick capsule. The capsule may weakly enhance after administration of contrast and can calcify in chronic lesion. There is no local invasion and only minimal mass effect on surrounding structure. The size and the appearance can change over time. A fat fluid level may be seen in areas of fat necrosis. On MR imaging, encapsulated fat necrosis usually appear heterogeneous on both T1 and T2 weighted with areas of high and low signal intensity. Inhomogeneous enhancement is seen after intravenous gadolinium-based contrast material administration. A peripheral rim of low signal intensity on both T1 and T2 weighted has been described and corresponds to the fibrotic peripheral capsule. Differentiating encapsulated fat necrosis from liposarcoma can be challenging. Patients with encapsulated fat necrosis usually have a documented history of surgery or trauma. Encapsulated fat necrosis is well circumscribed and has a surrounding capsule, whereas liposarcoma is usually less defined, lack a capsule, and may invade surrounding structure. Yes. and follow-ups. Neoplastic lesion, tumor of adipose origin. Lipoma is a benign mesenchymal tumor composed of mature adipose, whereas liposarcoma is a malignant counterpart. These tumors can occur anywhere in the body at any age. At CT, lipoma appear as a well-defined homogeneous mass with fat density. Areas of soft tissue attenuation may be seen within the tumor and may represent fat necrosis, septa, or normal adjacent structure. The presence of a predominantly solid soft tissue component or adjacent organ invasion should raise suspicion for liposarcoma. Retroperitoneal liposarcoma are classified into 5 groups: well-differentiated liposarcoma, myxoid liposarcoma, round liposarcoma, pleomorphic, and dedifferentiated. The imaging appearance of liposarcoma varies depending on the tumor group. Well-differentiated liposarcoma appear as a well-defined, predominantly fat-containing lesion with minimal soft tissue attenuation and commonly contain thin septum. The appearance may be indistinguishable from lipoma, and any retroperitoneal purely fatty lesion should be considered a well-differentiated liposarcoma rather than a lipoma until proven otherwise with histology examination. A dedifferentiated liposarcoma appear identical to a well-differentiated liposarcoma, and dedifferentiation is suggested by focal nodular or non-lipomatous region larger than 1 cm. Should be biopsied, yes. Nodule, soft tissue nodule more than 1 cm. As seen in this case, there's multiple masses of soft tissue attenuation. This is a dedifferentiated liposarcoma. This is the fat part, this is the soft tissue part. And this case, so well differentiated, only septa is visible. We have myxoid liposarcoma. Typically have lower attenuation than adjacent muscle, but higher attenuation than simple fluid. On CT image, it resembles the cyst, but the area of high signal intensity on T2 enhanced after contrast material administration. Round cell liposarcoma and pleomorphic liposarcoma exhibit soft tissue tumor attenuation and signal intensity with minimal amount of fat. These have minimal amount of fat. Infant or children, the most likely diagnosis for a well-circumscribed fat-containing lesion is lipoblastoma. Lipoblastoma. Yes. This is a case of liposarcoma, myxoid liposarcoma. Shows enhancement. A case of pleomorphic liposarcoma. There is no fat content. Most of the lesion is soft tissue. This lipoblastoma, 3 years old boy. Fat attenuation. Hibernoma is a rare benign tumor. It contains immature fat cells, brown fat, which are commonly found in large quantities in hibernating animals. On ultrasound image, the hibernoma are echogenic and may have well-defined or ill-defined borders Increased blood flow in large vessels on the surface of a hibernoma may be visualized at Doppler ultrasound. CT images hibernoma appear as fat attenuating lesion with attenuation slightly higher than that of subcutaneous fat. They usually contain enhancing soft tissue septa and calcification and are notably absent. Their appearance can be heterogeneous because they contain variable amount of brown and white fat, myxoid material, and spindle cell elements. The presence of large branching vessel within a fatty appearing lesion is strongly suggestive of hibernoma. And by positron emission tomography can be diagnosed has the potential to allow differentiation of hibernoma from other fat-containing lesion because of the presence of brown fat. Vascular. Retroperitoneal myelolipoma are benign lesions are histologically identical to adrenal myelolipoma. They usually occur in the presacral region but have also been reported in the perinephric space. The tumor may be large at presentation, ranging from 5 to 19 cm in diameter. The differential diagnosis for fat containing presacral mass include lipoma, liposarcoma, teratoma, extramedullary hematopoiesis, and lipomatosis. Unlike liposarcoma, myelolipoma are typically well-defined and do not exhibit an infiltrative growth pattern. Differentiating presacral myelolipoma from other fat-containing lesions may not always be possible with imaging alone. Presacral myelolipoma occur predominantly in elderly women, which is the single most useful feature for differentiating this tumor from other fat-containing presacral lesions. Ultrasound imaging the tumor vary in their echogenic pattern and may be hyper or hypoechoic, depending on the predominance of fat or hematopoietic element, respectively. On CT, they are well circumscribed encapsulated fat mass with avidity enhancing hematopoietic soft tissue element. The attenuation value of fat in myelolipoma is usually higher than that of retroperitoneal fat because of the admixture of hematopoietic tissue. Areas of intratumoral hemorrhage or calcification may also be seen. On MR images, areas of high signal intensity on T1 weighted image and intermediate to high signal on T2 weighted images with loss of signal intensity and fat suppressed image confirm intratumoral fat. Myelolipoma show variable enhancement depending on the proportion of hematopoietic tissue. Teratoma are usually seen in younger age and contain fluid-filled cystic component, whereas myelolipoma are typically seen in elderly patients and do not show cystic component, as seen in this case, presacral myelolipoma in an old age woman. We have retroperitoneal fat-containing germ cell tumors. Tumor teratoma are germ cell tumors that are commonly composed of multiple cell types derived from one or more of the three germ cell layers. Primary retroperitoneal teratomas occurs for 1 to 11% of retroperitoneal neoplasms and are most commonly found in neonates and young adults. About 1 to 2% of germ cell tumors originating in an extragonadal location. The retroperitoneum is the second most common extragonadal site for germ cell tumor after mediastinum. Mature cystic teratoma, primary retroperitoneal mature cystic teratoma are extremely rare. They are more common in female patients and have a bimodal age distribution with peak age in the first 6 months of life. Typical mature cystic teratoma appear as a well-circumscribed complex cystic mass that contains variable amount of fluid, fat, or sebum. Yes. 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 It's common. Mm. Yes. Case of retroperitoneal mature cyst teratoma. Mature cyst teratoma. Yes, typical. Malignant teratoma. Most malignant retroperitoneal germ cell tumors are metastases from primary gonadal germ cell tumors. Careful ultrasound examination of the testes is important in every patient with a retroperitoneal germ cell tumor to evaluate the patient for primary testicular germ cell tumor. Occasionally, the primary germ cell tumor is not visible or small intratesticular scars are found in patients with retroperitoneal germ cell tumor. These scars represent a regressed, burned out germ cell tumor. Gonadal germ cell tumors that contain immature teratomatous elements can manifest as a retroperitoneal mass that contain fat. Retroperitoneal germ cell tumors are usually large at presentation. The presenting symptoms and signs include palpable mass with or without pain, weight loss, constipation, hip and back pain, dyspnea, leg edema, fever, varicocele, and urinary retention. Encasement, displacement, and compression of the abdominal viscera are common. On imaging, both primary and metastatic malignant teratoma appear as enhancing soft tissue mass with foci of fat and calcification. This is a case of retroperitoneal metastatic germ cell tumor, foci of fat, soft tissue lesion with foci of calcification. Retroperitoneal paraganglioma arise predominantly from paraganglioma, which are symmetrically distributed along the abdominal aorta. The retroperitoneum accounts for 85% of all extraadrenal paraganglioma. In the retroperitoneum, the most common site of paraganglioma is the organ of Zuckerland, which is located anterior to the aorta at the level of the origin of the inferior mesenteric artery. Paraganglioma are commonly seen. Zuckergandel, yes. Are commonly seen in the third and fourth decades of life with no sex predilection. They can be associated with type 1 neurofibromatosis, multiple endocrine neoplasia syndrome, and von Hippel-Lindau disease. Extraadrenal paraganglioma are more likely to be malignant than adrenal pheochromocytoma. Patients with functioning paraganglioma present with variety of symptoms that result from catecholamine excess, including headache, palpitation, sweating, tremor, vomiting, chest pain, constipation, and visual disturbance. Yes. Yes. On CT images, paraganglioma usually seen as a large, well-defined, avidly enhancing tumor with the area of hemorrhage and necrosis. The tumor is highly vascular and large vessel can be seen around it. Punctate calcification is seen in 15% of cases, and fluid level can be seen due to intratumoral hemorrhage. On MR imaging, paraganglioma are usually hypo or iso compared with liver parenchyma with signal voids on T1 weighted image. Small tumors are markedly hyperintense, while larger tumors usually show variable signal intensity on T2 weighted images. Radionuclide image performed after administration of iodobenzyl show high uptake in paraganglioma and is sensitive technique for localizing these lesions in patients who present with suggestive symptoms and with show laboratory evidence of catecholamine excess. As with the adrenal pheochromocytoma, microscopic and macroscopic fat is rarely found in retroperitoneal paraganglioma. Ganglioneuroma is a rare tumor that arises from autonomic ganglions of the peripheral nervous system, usually the sympathetic ganglion. They represent the benign end of the spectrum, whereas ganglioneuroblastoma and neuroblastoma is malignant. Yes. Yes. Ganglioneuroma are most commonly within the posterior mediastinum and retroperitoneum. Less commonly, they may arise in the adrenal medulla parapharyngeal region. Ganglioneuroma occasionally secrete hormones such as catecholamine, vasoactive intestinal peptides, or androgenic hormones. This tumor is commonly seen in 20 to 40 years old age group. Lipomatous ganglioneuroma, previously called ganglioneuroma with fatty replacement, is extremely rare variant of ganglioneuroma that was first reported in 1999. On CT image, ganglioneuroma is depicted as a well-circumscribed, lobulated, hypoattenuating mass that may surround a blood vessel without narrowing the lumen. Ganglioneuroma may grow through the adjacent intervertebral neuroforamen and extend into the spinal canal with a dumbbell or hourglass configuration. Discrete punctate calcification are seen in 20 to 30%. Necrosis and hemorrhage are uncommon. The presence of fat is unusual. After contrast administration, ganglioneuroma usually demonstrate characteristic mild enhancement during the arterial phase and progressive delayed retention of contrast material on delayed phase image. On MR imaging, ganglioneuroma is homogeneously hyperintense on T1, varying signal on T2 weighted images depending on the myxoid cellular and collagen component, and old appearance on MR imaging has been reported and is due to interlacing bundles of longitudinal transverse Schwann cells or collagen fibers. Generally, ganglioneuroma are larger and have more calcification than do nerve sheath tumor. The prognosis is good after surgical resection. Retroperitoneal ganglioneuroma, a case shows focus of fat surrounding the vessels, the aorta, but not invading it. Extramedullary hematopoiesis is abnormal deposits of hematopoietic tissue outside the bone marrow as a compensatory mechanism. Is not a true neoplasm. It can manifest as mass in the retroperitoneum. The condition is seen in hemoglobinopathy, myelofibrosis, leukemia, lymphoma, and carcinoma. Retroperitoneum is a common site which is typically found in the liver, spleen, and lymph nodes. Common site of involvement in the retroperitoneum include the paravertebral, perinephric, and presacral region. Perinephric involvement of the extramedullary hematopoiesis is rare and appears as a soft tissue mass intermixed with fat or as a diffuse uniform infiltrative process that surrounds the kidney. Splenectomy may have a role in accelerating development of extramedullary hematopoiesis. The presence of fat in extramedullary hematopoiesis mass is indicated of all inactive lesion. The typical CT appearance is round or lobulated mass with soft tissue attenuation with or without macroscopic fat. MR appearance varies according to the proportion of active and inactive marrow. Active extramedullary marrow usually appears as a well-demarcated iso-intense or hypo-intense mass on T2 and on T1 and T2 weighted image. After contrast material administration, there is always some enhancement in active extramedullary hematopoietic lesion. Areas of fat infiltration within old inactive disease demonstrate high signal on T1 and T2 weighted image. Yes. 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 The diagnosis is evident by history of hemoglobinopathy, hepatosplenomegaly, and characteristic skeletal changes of marrow infiltrative process. Thank you.
Just a second.